Chapter 28, the child with cerebral dysfunction. We're continuing on looking at drowning and near drowning. Drowning is a mortality. The child dies. Near drowning means they survive for at least 24 hours. It does not mean we have a good outcome. There can still be significant deficits left. Now, this is our second most common accidental cause of death in children after motor vehicle accidents. 40% of the time they're going to be less than 5 years of age, and 90% of the time these occur in private swimming pools. Those ones that are not in a swimming pool, though, it doesn't take a lot of water. It can be just a few inches of water that a child can drown in, and for toddlers, things like toilets and buckets can be dangerous. They lean over, they're so top heavy with their big heads, they fall in head first, but then they're not very strong to be able to push themselves out. The younger the child is, so an infant or a toddler, actually can withstand submersion a little longer. Their brains are just a little more resilient, but we're still only talking, 4 to 6 minutes before you've done irreversible damage. One of the things our body does is this diving reflex. So when you are submerged in water, your body shunts the blood away from the periphery and the less important organs and sends blood primarily to the brain and the heart, because those are our two most important organs and the two that tolerate hypoxia the least. Here's a picture of a child intrigued by a pool. So, what's the pathophysiology? Hypoxia is our biggest problem. That's what causes all of the problems. We get atelectasis, partly because you're not breathing and partly because of that shunting of the blood away from the lungs. Respiratory acidosis, because you're not breathing and blowing off that CO2. Metabolic acidosis, because cells are having to use anaerobic metabolism, making those acidotic waste products. So that is the big problem, hypoxia and the acidosis that goes along with it. Aspiration, 90% of the time the child will aspirate some water, 10% of the time they won't. And really, whether they aspirate or not, it doesn't matter if it's fresh or salt water, it makes no difference. The problems that aspiration causes are things like pulmonary edema, atelectasis, airway spasm, and pneumonitis, which of course all make that hypoxia worse. And then hypothermia. Children have that larger surface volume to their mass, which means you put them in water that's below body temperature and they lose temperature by conduction out into that water more at a higher loss than an adult does. So if they're in a spa that's above body temperature, then you don't have that hypothermia, but any water below body temperature. Now, management really depends on the degree of cerebral insult that's happened, but our first priority is always restoring oxygen. The big problem is the hypoxia, so first priority is getting them breathing, getting oxygen into them. All children who have gone through a near drowning should be hospitalized, even if they look like they're doing fine. They should be hospitalized for at least 12 to 48 hours because respiratory distress and cerebral edema can worsen, and what may not look bad initially might actually be bad in a few hours. Aspiration pneumonia is also something we're going to have to be watching for and concerned about, and that usually isn't going to really be evident until 48 to 72 hours later. And we need to help these parents cope. They not only are in the middle of a very stressful situation with their child hospitalized, but usually there's a lot of guilt. They feel like they should have been watching, they should have made sure the chain was locked, the gate was locked, whatever. They feel very guilt-ridden. And then, as nurses, we have a role to play in prevention, encouraging people with pools to have them fenced, Make sure they have self-shutting and self-locking gates, and that toddlers aren't near pools unsupervised. I've heard of any number of near drownings or actual drownings where there were lots of people around. It was a party. Everybody was there, and everybody thought someone else was watching the pool. So at a party, someone should be designated at all times to be sitting and staring at the pool. They're not talking, they're not wandering around, they're just watching the pool, and any kids who are in the vicinity of the pool. Okay, brain tumors and neuroblastomas. Brain tumors, this is the second most common cancer of children after leukemia. 60% of the brain tumors we see in kids are down in the cerebellum or the brainstem, and they usually come from the gliomas, the glial cells. So this is not neurons, it's not actual brain tissue, it's the supporting tissues of the brain. How do we diagnose these? Well, usually it starts with signs and symptoms of increased ICP. It takes up space in the brain, and that skull can't absorb or stretch, right? So you get increased intracranial pressure. So you're going to see headache, especially when they wake up, and vomiting that's not related to feedings. We're going to use MRIs and CTs for diagnosis. They'll probably do an angiography, so they're going to inject a dye into the blood and watch where it goes through the brain, because tumors do have a very large blood supply. They develop their own blood supply. We may need to do an EEG looking at brain activity. They might do an LP to see if this is something that has moved in to the cerebral spinal, showing signs in the cerebral spinal fluid. However, remember, an LP is dangerous when we have increased intracranial pressure. When you release that pressure below the brain, that pressure up above inside the skull is going to push down, and you can herniate the brainstem through the tentorium. So how's it managed? Well, surgery, radiotherapy, so the x-rays, and then chemotherapy. And we're going to need to treat high or low ICP depending on what happens from the treatments we're giving. We need to be very careful with our neuroassessments, give very detailed neuroassessments, and anytime we see a temperature in these kids, we're going to worry about infection, where we'll suspect infection anytime there's a temperature. We do not want these kids in Trendelenburg. We don't want their head down where we can increase the ICP. We want them up a little bit, elevated head a bit, and we really need to support both the child and the family. This is traumatic. So neuroblastomas, these are the most common malignancy during infancy, and this comes from the embryonic neural crest cells that turn into the adrenal medulla and the sympathetic ganglia. Most of these tumors are going to be in the adrenal gland or retroperitoneal in the sympathetic lymph chain there. 70% of the time, this is not going to be diagnosed until after it has metastasized. And because of that, the younger the child is when we catch it, the more likely we can catch it early before metastases, so better prognosis if we catch it younger and earlier. Okay, infections. Bacterial meningitis is one of the big infections we're concerned about. Usually these kids are under 5, 90% of the time they're under 5, and even younger than that, infants during that first year of life are at the greatest risk. The other little spike that we see is late teens, that kind of going off to college age and then they live in a dorm and they don't eat well and they don't sleep and all those things, and we see an increase in bacterial meningitis among kids that age as well, but still 90% of the time they're kids under 5. Common organisms: Haemophilus influenza, Staphylococcus pneumoniae, and then meningococcal, which is the Neisseria. That is 95% of the time in children who are who are older than 2 months. The youngest ones most often are going to be the Haemophilus influenzae, and that's the one we have the Hib vaccine for, and the meningococcal we also have a vaccine for now. So the meningococcal is the one we see in that those adolescents that going off to college age kids and school age. So how does it get in? Well, through the nose, through the ears, really through anywhere, and then somewhere where it gets in and is picked up in the vasculature, in the blood, and brought around and settles into the meninges. So the meninges become inflamed. They have exudate. So you're going to see increased WBCs and tissue damage happening in those meninges around the brain. That exudate, we're going to have some increased ICP just from, and basically you can have pus around the brain. So your brain, you can have edema, you can block the CSF flow, which also is going to contribute to increased intracranial pressure. This is relatively common with a severe case of the meningococcal. You get that purpura. Okay, so how do we diagnose it? Well, first on signs and symptoms. We should have a fairly abrupt illness. It's not something that kind of slowly happens. Fever, headache, vomiting, altered sensorium, and these kids will complain of light photosensitivity, and actually that's down at the bottom there, photophobia. They may have seizures. Mucorigidity. If you try and bend the head forward so that the chin is touching the chest, that is extremely painful. And then I have a slide about this Kernig's and Brudzinski's signs. Labs, what we're going to do, the main way we diagnose it is with that lumbar puncture, and they'll do a cell count. They look to see if they can see any germs in it. We'll do a culture and a sensitivity. They're going to look for protein and glucose. If our proteins are elevated, that's basically what a germ is. It looks like a protein. If it's bacteria, it uses the glucose for reproducing. So we will see high protein and low glucose. Our body's going to send in WBCs trying to do what it can to combat this infection. So we're going to see high WBCs. This is all in our spinal fluid, and those WBCs will mostly be the polynucleated polys. On that glucose, it's nice if we can compare it to a serum glucose, just so we know the child wasn't hypoglycemic overall, that it's only in the LP. An infection in the meninges, we're going to increase the permeability of that blood-brain barrier, so what fluid that shouldn't be able to move across does, all of which contributes to increased intracranial pressure. And then we're also going to want to do a blood culture, because we said often this is got to the meninges through the bloodstream.